Good afternoon, everyone. My talk is COVID-19 and pre-sepsin. So we are now using the sepsis 3 criteria, and the sepsis is newly defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. And to define septic shock, we have to measure mean arterial pressure and the serum lactate level. And the triad of sepsis is so infection, host response, and organ dysfunction. And we are using SOPA score to describe multiple organ failures in sepsis, which is based on 6 different subscores. But it is ironical, we use still SOPA score, which was introduced already 25 years ago to newly define sepsis. And then from this original investigation, it had some limitations in terms of cardiovascular status and coagulation system evaluation. And it also has several limitations in terms of cardiovascular subscore, which is dependent on the adrenergic support, and the renal subscore, which is still using serum creatinine level with a lot of limitations. So in addition to the clinical diagnosis of sepsis, there is always room for further improvement using biomarker approach in sepsis. So WBC, CRP, and procalcitonin are well-known inflammatory variables in sepsis, and procalcitonin was first reported in 1993 with its association with bacterial infection. Compared with CRP, procalcitonin may show better specificity, time advantage, and close correlation with septic severity and outcome. And pre-sepsin is a soluble protein fragment by cleavage through proteases from bacteria, which is specific for sepsis. And pre-sepsin can be produced via monocyte macrophage system, and later it would stimulate the production of IL-6, procalcitonin, and CRP. And compared with procalcitonin and CRP, pre-sepsin is known to be more infection-specific with short response time after onset and short half-life in blood. And it is used clinically under the coverage of National Health Insurance in Japan since 2014, as well as procalcitonin. And several large clinical trials have shown its better performance, a better prognostic performance compared with procalcitonin. And in that Albios trial, differently from procalcitonin level, at all the 3 time points of day 1, day 2, and day 7, pre-sepsin levels were significantly higher in the descendant than in the survivors. And the same finding was also observed in septic shock patients. So we also tried a multi-marker approach in sepsis using procalcitonin, pre-sepsin, soluble ST2, and galectin-3 with Salvatore, and we could show that this multi-marker approach predicted 30-day mortality better than SOPA score. And in our analysis, except for procalcitonin, the other biomarkers showed good prognostic performance like SOPA score. And this multi-marker approach added on SOPA score showed improved predictive ability in sepsis. So we could conclude that compared with procalcitonin, the other novel biomarkers showed superior prognostic performance, and their combined use reflected the clinical outcome. And we also compared the pre-sepsin and procalcitonin in early diagnosis of neonatal sepsis and could show the diagnostic superiority of pre-sepsin over procalcitonin. And in our meta-analysis with Professor Yang, we investigated the prognostic value of pre-sepsin in adult septic patients and in terms of overall mortality and mortality with the short-term follow-up interval. And in our subgroup meta-analysis by sepsis severity and study site, we could show the prognostic value of pre-sepsin in septic patients. Now let's talk about COVID-19. As we know, the main root of COVID-19 SARS-CoV virus is ACE2 receptor, which is prevalent in the lung and in the heart. But in addition to the heart and lung, ACE2 is expressed in the intestinal epithelium, vascular endothelium, and kidneys, providing a mechanism for the multi-organ dysfunction. So according to the disease progression, the host response is changed, resulting in the alteration of main biochemical parameters. And this table shows those main biochemical parameters alteration. And in addition to these conventional parameters, presepsin and MDW means monocyte distribution width, another US FDA-approved sepsis biomarker, and these biomarkers are regarded potential for the early identification of patients at increased risk of complications. So this is the first study that showed the utility of presepsin in risk stratification of SARS-CoV-2 patients. After this first small study, several studies explored the utility of presepsin in terms of prognosis prediction. So actually, COVID-19 has a mirror image of sepsis. So the main cause of death by COVID-19 include respiratory failure and the onset of sepsis. And sepsis has been observed in nearly all deceased patients in many of the reported cohorts with significant changes in the host immune response. And monocyte macrophages are the principal players in orchestrating the host inflammatory response. Actually, COVID-19 is a dynamic disease, and in its early phase, the innate immune system is related to the cytokine storm, and we can see IL-6 here, and its late phase is related to the adaptive immune system, and then the immune tolerance and reduced T helper 1 response and cytotoxic activity can be found. So for the clinical assessment of COVID-19, the WHO severity system is regarded as a gold standard, and sepsis and septic shock are included in the critical disease category. But a recent paper compared several proposed scoring systems, but unfortunately, this comparison didn't include the gold standard WHO severity score as well as SOFA score. And we know that age appears to be a relevant and strong predictive factor of in-hospital mortality in cases of severe or critical SARS-CoV-2 infection. And then a recent paper also proposed another VACO index based on a large data from the states. And VACO index could differentiate the risk of 30-day mortality among those of similar age. And then the prognostic utility of VACO index for predicting short-term mortality was again proven in the successive study. With such a background, we explored the prognostic utility of procalcitonin, presepsin, and the VACO index for predicting 30-day mortality in hospitalized COVID-19 patients, and could show the utility of these biomarkers and VACO index. And in the Kaplan-Meier survival analysis, presepsin showed the highest hazard ratio, and that value was again confirmed using the reclassification analysis. So presepsin and procalcitonin, in addition to the VACO index, may be a more reliable prognostic approach than using the VACO index alone. But interestingly, procalcitonin, although most patients presented with sepsis or septic shock in this study, the median procalcitonin levels in survivors and non-survivors were all below 0.5 nanogram per milliliter. So the prognostic utility of procalcitonin in COVID-19 is arguable because it is in the normal range in most patients. Now we can think about the other emerging biomarkers of KL6 and interferon lambda 3. So post-COVID-19 pulmonary fibrosis is a novel sequelae of the current pandemic, and pulmonary fibrosis is a subset of interstitial lung disease. Actually, fibrosis is a pathologic feature of disease in virtually all organs, sharing common pathogenic pathways. And KL6 is a novel biomarker for interstitial lung disease. And a recent study showed that KL6 could predict COVID-19 disease severity. So we explored the usefulness of KL6 and compared that with age and Charlson Comorbidity Index and WHO disease severity. And we measured initial and follow-up KL6 level. So KL6 level quartiles were associated with ICU admission, ventilator use, and ECMO use, except 30-day mortality, and initial KL6 level differed significantly according to ICU admission, ventilator use, and ECMO use. And follow-up KL6 level was significantly higher in non-survivors than in survivors. And in ROC curve analysis, initial KL6 level predicted ICU admission, ventilator use, and ECMO use better than age, CCI, and critical disease. And these parameters predicted 30-day mortality comparably. And using the Kaplan-Meier survival analysis, only age and initial KL6 level showed significant findings. So KL6 could be an objective biomarker for predicting clinical outcomes in hospitalized COVID-19 patients. Interferons are the potent multifunctional cytokines secreted by various cell types. And in SARS-CoV-2 infection, viral proteins block type 1 and type 3 interferon responses by inhibiting innate recognition of the virus, the production of interferons, and interferon signaling pathway. And interferon lambda is known to be against viral load and hyperinflammation. And a recent paper showed that interferon lambda 3 could predict COVID-19 disease severity. And another system named COVID-19 Severity Index was proposed as a triage tool. So we wanted to explore the prognostic utility of presepsin, interferon lambda 3, and COVID-19 severity index in hospitalized COVID-19 patients. And in 60 hospitalized COVID-19 patients, the 30-day mortality rate was nearly 12%. And both interferon lambda 3 and COVID-19 severity index were significantly higher in ICU patients than in general ward patients. And presepsin and COVID-19 severity index were significantly higher in non-survivors than in survivors. So presepsin could predict renal replacement therapy and 30-day mortality significantly, while interferon lambda 3 could predict ICU admission and renal replacement therapy significantly. So presepsin and interferon lambda 3 could be used complementarily in clinical practice to predict clinical outcomes in COVID-19 patients. So multi-marker approach using conventional emerging biomarkers would be quite useful in critical care, and presepsin can be a good and potential biomarker for sepsis and COVID-19 patients. Thank you very much for your kind attention.
Any question from the audience?
That was fantastic, thank you. So when presepsin is involved with like a gram-negative bacterial sepsis, it's very clear how it gets activated and why you get presepsin release from the CD14. How does that work for other pathogens? I mean, what would be the mechanism by which the CD14 would be cleaved and released in COVID or, gram-positive?
Well, as we could see that I think monocyte macrophage system is very important related to bacterial infection or any virus infection. So it can do the orchestrating role and the host immune response. So I think regarding that, although I commented MDW, monocyte distribution width, that is freely obtained parameter using hematology analyzer, and it has also US FDA approval as a sepsis biomarker. So that is also from monocyte. So like presepsin and MDW, I think monocyte macrophage system plays a key role preventing host from other bacteria or viral invasion. So, yeah.
Thank you for your interesting presentation. I was just wondering, you were using percepsin and you compare it to several biomarkers to predict mortality in patients with sepsis, but did you consider comparing with high-sensitivity troponin? Is this better than the high-sensitivity troponin for prediction of mortality in patients with sepsis? Your AUCs are all 0.7 or?
Oh, unfortunately, I couldn't have such a chance to compare presepsin with troponin, but I think it will reflect some different aspect of disease severity in the host. Yeah, so that would be a good chance to compare those biomarkers together. Yeah. But compared with the procalcitonin, I think anyway, based on my own experience and based on the literature, for the diagnostic ability, I think those biomarkers are a little bit equal, but the prognostic performance, I think presepsin is stronger than procalcitonin.
Thank you very much. Thank you very much.